I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Matt Covington, an assistant professor of radiology from the University of Utah and Huntsman Cancer Institute, and he'll be discussing his recently published AJR article, Prospective Pilot Study of Fluoroestradiol PET-CT in Patients with Invasive Lobular Carcinomas. Matt, thanks for joining us today.
Thank you for having me. I'm really excited to share my research with your audience today and to discuss this with you.
Great. So to start off, please explain for us the basic principle behind why this agent is being used to evaluate patients with invasive lobular carcinoma.
Invasive lobular carcinoma is a very special subtype of breast cancer. It's the second most common type of breast cancer and accounts for about 15% of all breast cancer cases. And the interesting thing with invasive lobular carcinomas are that they are difficult to detect on many imaging studies, whether mammography, ultrasound, sometimes tricky on MRI, often not showing abnormal uptake on FDG PET-CT. Invasive lobular carcinomas are also nearly uniformly estrogen receptor positive. So the rationale with fluoroestradiol is that fluoroestradiol images estrogen receptors on PET imaging. Therefore, a cancer that highly expresses estrogen receptors, such as invasive lobular carcinoma, might really be ideal to image with FES or fluoroestradiol. I'll just call it FES for short. That being said, there is not a lot of work that's been done to evaluate fluoroestradiol for lobular carcinomas to date. I think we'll get into some of the research that has been conducted, so we'll get to that in a moment. But I personally was very interested to see if we have a dedicated study population of patients who have a recent histologically proven diagnosis of invasive lobular carcinoma, what can FES show us about their disease and what type of detection will we see? So that was what got me started down this path in the first place.
Thank you for that explanation. So you mentioned some prior work in this area. Can you summarize what's been done previously leading up to your study?
Yes. One of the primary articles that comes to mind when you think of fluoroestradiol imaging for lobular carcinomas is a fantastic study by Gary Ulaner. This was a meta-analysis from a single institution where they had done multiple FES trials, and they went back and specifically looked at how FES performed for patients with lobular carcinomas. And really those results were very encouraging. In terms of ILC specifically, to my knowledge, there are no other pre-existing trials of FES specifically for lobular carcinoma. That being said, there's no shortage of research on FES PET. We've had decades of experience with this agent, and that has shown us a few things. First of all, FES binding is a very good surrogate for estrogen receptor status, that we know. In general, the research that exists on FES for breast cancer, which mostly comprises study populations of ductal carcinoma, at least predominantly ductal carcinoma, that data has generally been encouraging as well. The clinical use of FES has now arrived in the United States, and many centers are using this clinically. That being said, there is still a lot that we didn't know about FES for lobular carcinoma. After my initial pilot study, there's still a lot that we don't know. I've maybe raised more questions in my mind than I had initially before I embarked on this path, but I think that's how the process of research goes. Generally, though, I would say to summarize all of it, findings are very encouraging that FES PET imaging will be very helpful to us for all types of ER-positive breast cancer. I personally am excited to especially see what it can do for lobular carcinoma patients, given the diagnostic difficulty with standard imaging that many of these patients do experience in the clinics.
Great. Okay, so we'll now walk through your study.
Great.
So this was done prospectively. Could you explain for us who was recruited into this?
Yes, so we did have prospective enrollment on this trial. I really didn't place a lot of limitations on who could join the trial. Limitations that did exist, you had to have a recent diagnosis of lobular carcinoma from biopsy within 12 weeks. I didn't limit it to any specific anatomic site in the body. It's probably not surprising that most of these patients did have a breast primary that was recently biopsied. And therefore, a lot of patients that ended up on the trial were early stage lobular carcinomas following the initial diagnosis. That being said, we also had two cases that presented with biopsy of metastatic lymph nodes. We had one patient who enrolled following endoscopic biopsy of the stomach that revealed lobular carcinoma. By and large, most of these patients were referred after initial diagnosis from breast surgeons or oncologists here at the Huntsman Cancer Institute.
Great. Those are the patients who were enrolled. And now could you explain for the patients on the trial what interventions were done as part of participation and how the imaging was interpreted?
Yes. So the trial design was really pretty simple. Everybody had to have an FES PET-CT scan. That was obviously an important and mandatory part of participation in the trial. We wanted to have as many FDG PET-CT scans as well for comparison. So we did two things. First, if the patient had a recent clinical FDG PET-CT, we allowed that to be included on the study. Given that most of these patients were early stage, most of them did not have an FDG PET-CT because it was not indicated by NCCN guidelines. They were too early stage. So for every patient who was enrolled who didn't already have an FDG PET scan, the study did offer at no cost to the patient an FDG PET. We ended up with 13 out of 17 enrolled patients who had FDG PET. All 17 of those had an FES PET. The reading of the studies were, I was one of the primary readers. The other was Dr. Catherine Morton, who's a very experienced and wonderful nuclear medicine radiologist. And we both looked at the scans. We were not blinded in terms of prior imaging. We knew all of these patients had lobular carcinoma. I allowed us to be able to see where in the breast that was. We had access to prior breast imaging. My thought on this, and we could have gone either way, we could have potentially designed this differently, but I wanted this to be analogous to what you would actually do in the clinic. And that includes knowing what past history the patients have. Additionally, I had some concerns whether we could truly blind ourselves even if we tried, because we knew all of these patients would have a recent biopsy to be on the trial, and CT imaging on a PET is good enough that you can see where biopsy clips are in the breast. So we did read these. Any cases where we had any disagreement, we discussed together. There were only 2 of those. We did have a third reader ready for an additional opinion if necessary, but we did not need that third opinion on any case. We generally agreed. We also did, similar to other studies, use a quantitative SUV max cutoff of 1.5. Anything below 1.5 we considered not disease. Anything over 1.5 was disease. So every site to be considered positive, first of all, had to look positive to us qualitatively, meaning focal uptake above that of background tissue in that region. And we also had to have a quantitative measure of SUV max exceeding 1.5.
Great. So in the trial, you had a very well-defined primary endpoint with a null hypothesis that was being tested. So what was that null hypothesis and how did you come up with it?
So In designing this trial, there were some logistic challenges, primarily that we did not have a lot of data upon which to base a power calculation or design a trial. Again, to my knowledge, this is the first prospective study on a dedicated population of lobular cancer patients with FES. So what we settled on is that a reasonable first step could simply be to evaluate the rate of abnormal uptake at histologically proven sites of lobular carcinoma. I looked in the literature and found what data I could on the expected uptake rate of FES PET for lobular carcinomas, or of FDG PET, sorry, there wasn't really data we could base it off on FES. And so the design was that we would try to prove that we were getting at least equivalent, if not higher uptake of FES compared to FDG. And the benchmark, you could say we were trying to prove FES could at least achieve was a 60% positivity rate at sites of biopsy-proven lobular carcinoma. So that was what our study was powered for. That was the primary endpoint.
Great. And then what did you find for that endpoint?
So first of all, the study population was powered for 24 lesions. We ended up with 25 histologically proven lesions because the final patient had 2 sites. Out of those 25, 22 sites did show abnormal uptake on FES PET CT, which was an 88% positivity rate. And that was significant to reject the null hypothesis. The p-value was 0.002 for the primary endpoint.
Great. So then you had a series of secondary analyses, and these included additional sites of ILC that ended up being diagnosed after enrollment. So could you summarize what was found from some of these secondary analyses?
Sure. The secondary analyses I found really interesting in this study. We have to be cautious on how we interpret these results because they are simply preliminary. It's a small study population. This was an initial trial, and we weren't powered to evaluate these endpoints. Nonetheless, we found some interesting findings. One thing we looked at was how many additional lesions would we identify on FES PET CT compared to standard of care imaging. And we ended up finding out of 17 patients, 4 additional lesions. These were 2 cancers in the other breast of where patients had a known lobular carcinoma, as well as 2 metastatic axillary lymph nodes that had gone undiagnosed on ultrasound and MRI in these cases. All of these ended up being confirmed malignant on histopathology. Another secondary endpoint was to evaluate for any change in clinical stage of patients enrolled on the trial. And we did find that FES changed the AJCC clinical stage in 3 of 17 patients. That's 18%. The change in clinical stages in 2 of the 3 cases occurred due to detection of positive axillary lymph nodes that were previously unknown. And then in the 3rd case, it was actually downstaging what looked like a suspicious lymph node on standard of care imaging, but FES showed absolutely no uptake. We did see a high frequency of abnormal uptake that did exceed that seen on FDG PET CT in numbers, but this was not statistically significant. So in other words, FES PET imaging did identify additional sites of disease at a numerically higher rate than FDG PET CT, but not statistically significant rate. So we need to be aware of that. This could be due to small numbers, I don't know. FDG PET CT did detect many lesions, but simply not as many as FES did. So one thing I do also want to mention, we did not limit enrollment to ER positive cancers. If patients had an ER negative lobular cancer, we were more than happy to have them on trial. Part of the intention was we wanted to see how FES would perform in cases where we would expect no uptake. The trial had one patient with ER negative disease enrolled, and surprisingly, this patient did show definite abnormal uptake at the site of histologically proven ER negative malignancy. And we can't draw many conclusions from a single case, obviously, but one could ask why could we have seen that? Why might have FES shown uptake at a site where you would have predicted no uptake? One potential is that there is heterogeneity in tumors. I think PET imaging is showing us more and more as we get various agents, whether FES or PSMA or what be it, the tumor expression of receptors can be heterogeneous. And maybe in this case, the biopsy was of an ER negative portion of the tumor, but there were also ER positive portions. Perhaps there's another mechanism we don't currently well understand. Maybe support cells around ER negative tumor have some estrogen receptor expressions. I've seen some basic science research hinting that that could be the case, but we really don't know.
Great. And then just one last question as to the study findings. So for these additional sites that were detected in the contralateral breast, a number of these were DCIS or invasive ductal carcinoma. Could you just comment as to what you make of that observation?
Sure. First of all, FES is not specific for lobular cancer, and I think anyone reading the study results or watching this needs to understand what FES is imaging is estrogen receptors, okay? And ER positive or estrogen receptor positive tumors can occur with lobular cancers, also ductal cancers, also DCIS. So any ER positive breast cancer could potentially show uptake here. The significance of identifying cancer in the contralateral breast is really, there's a lot of significance there, a lot of potential change to patient management. It's generally something we try very hard to avoid, to send a patient all the way to surgery, maybe radiation therapy, and have cancer undiagnosed in the contralateral breast. We know lobular carcinoma patients have a high rate of bilateral breast malignancy. That's a classic teaching in radiology and in medicine. And I think what we're seeing here is more of that theme, that lobular cancer is associated with other breast cancers, whether in the same breast or the contralateral breast. There's a reasonably high rate of that. We have several studies that can help us identify that. Primarily, breast MRI is heavily used for that indication. In this case, it was interesting to me that FES also was identifying many of these cancers in the contralateral breast. Maybe that could be clinically useful in the future. We'll have to see what future research studies show us on that.
Great. And so one last question for our readers who may now be more interested in this agent after reading your work. Could you just comment on the agent's availability and implementing it in practice?
Yes, so fluoroestradiol is available in an FDA-approved clinical form. This is called Cerianna, starting with the C, Cerianna, and it is clinically available at many sites in the country. But the clinical rollout of Cerianna is, in many cases, still early. There are a lot of centers, including Huntsman Cancer Center, which is one of the only major cancer centers in this whole region of the country, that do not yet have access to Cerianna. I'm really looking forward to that. Many other places, especially on both coasts, do have access. Cerianna is FDA approved for various indications to evaluate ER positive malignancies. There's a lot of nice recent and forthcoming review articles for any of the readers that are interested in this that you can look up, discussing the approved indications and current uses of Cerianna. But main theme to emphasize is that this is not purely a research agent at this point. Although we used a research formulation of fluoroestradiol on this study, there is a clinically available agent at many centers. And we are still, though, figuring out the best uses for this agent, in my opinion. We have some good established use cases, but for example, Sirion is not specifically approved for evaluation of patients with lobular carcinoma. There are some other indications as well that should be considered, and we definitely need a lot more research on the clinical use of FES PET imaging. We also need a lot more research on lobular carcinoma separate from invasive ductal carcinoma, because lobular carcinoma is a distinct entity from ductal carcinoma, and it probably deserves its own treatment and diagnostic pathways, in my opinion, and many others as well.
Great. So Dr. Covington, this was a really helpful conversation. I look forward to future research from you and your team as to the use of this agent. And thank you again for joining us in this conversation.
Thank you very much. And I just want to close and say thank you to the Fight for the Fight organization and Huntsman Cancer Institute for supporting this trial and future trials on FES imaging. And all of the co-authors as well. As you know, any study like this is the result of a large team effort and a lot of support from many different groups and people. So thank you to everybody who helped me with this.